Thank you for inviting me to have this talk. So as I spoke earlier, I'm going to talk about management of peritoneal surface malignancies. So here in Sheba Medical Center, we have a majority of cases of peritoneal surface malignancies, and I'm going to talk the modalities that we treat them in order to help the patients. I have no disclosures. As I presented earlier, I always like to present our team led by Professor Aviram Nissan, my colleagues, Dr. Adila, Dr. Lux, and myself. The treatment modalities that I want to talk to you about today is the cytoreductive surgery in HIPEC, the PPAC pressurized intraperitoneal aerosol chemotherapy, and the intraoperative radiotherapy. We believe that every patient has the needs to have the best treatment option that we have, together with the oncologist, together with the radiologist, together with interventional radiologist, and together with us, we try to give the patient the best treatment. And from our side, the surgical oncologist, we give the three modalities, and Sheba is one of the fewest fewest hospital in the world that have the three modalities in the same hospital. We'll start talking about the CRS and HIPEC, and the oncological idea behind it is the search for the ideal combination therapy for locally advanced tumors, and the classic interdisciplinary approach to prevent recurrence and to prolong life. Which tumor type do we treat? Two tumor types: the primary peritoneal surface malignancies, mesothelioma, and the secondary peritoneal surface malignancies, the appendiceal cancer, colorectal cancer, which are the majority, and then gastric cancer, ovarian cancer, and some rare tumors as sarcoma. Actually, the pioneer of the CRS and HIPEC is John Pratt, which I did not show here, but the pioneer of the modern era is for the HIPEC procedure, CRS and HIPEC, is Paul Sugarbaker, who invented and introduced the world the peritonectomy procedure, together with the peritoneal cancer index and the completeness of cytoreduction, which we know today are important for the overall survival and the relapse-free survival. Worldwide, since the introduction of the CRS and HIPEC procedure, it has gained more and more publicity. More and more centers around the world are practicing in CRS and HIPEC. More and more cases per year we can see in each center, and more publications per year in the literature. It's all about teamwork. So it's not as we used to know before. I'm the surgeon, the old-fashioned surgeon. I know everything. I do everything. And that's it. Whatever I say, it's the top. Now today we know it's teamwork. As I said before, oncologists, medical oncologists, surgical oncologists, interventional radiologists, and radiologists, all of us together give the patient the best treatment modality that we can have. Going back to only oncological treatment, if you look at peritoneal metastases, as we know today, the best treatment, the best oncological treatment for patients with peritoneal metastases will give up to 30-month median overall survival. And this leads the surgical community, community to actually look for another modality that will give the patient better overall survival and better relapse-free survival. And doing it by the CRS and HIPEC, and since the beginning of the 2000s, actually you can see in 2003, the first randomized trial for Vic Varwell, a good colleague of us, showed that the treatment divided a randomized trial into two groups. One group with CRS and HIPEC, the other group only with standard therapy with chemotherapy, and there was a major difference with the median survival of 12 months of the standard arm and for 22 months in the CRS and HIPEC arm. Of course, the same paper showed also that if we leave residual tumor or more than number of area affected, the overall survival also, of course, decreased. Going forward to the next few years, few groups from mainly France and Sweden showed retrospective and prospective data regarding the CRS and HIPEC and the ability of the CRS and HIPEC to improve survival and relapse-free survival. If you look at one of the papers of Elias and his group from the French team, 2010, we can see that two major prognostic factors, as I mentioned before from sugar breaker, showed that the complete substantive site reduction, which means the best surgery that I will have, and the peritoneal cancer index are two prognostic factors. The lower the peritoneal cancer index, the PCI, the better the overall survival, and the better surgery I will do, which means the better complete substantive reduction, the better survival the patient will have. Going forward to 2016, ESMO consensus guidelines also published that the HIPEC is very important and probably will be the future. And with the recommendation 17 from these guidelines, they say that complete site reduction surgery in HIPEC can be considered for patients with limited peritoneal metastases, which is an emphasis, in status which are very experienced in the use of CRS and HIPEC. And cytoreductive surgery in HIPEC is on the verge of becoming accepted standard treatment approach for patients with peritoneal surface malignancy for colorectal primary. So everyone were happy by that, but by the time of 2018, Francois Quinet, another very good colleague of mine, published a randomized prospective trial to randomize more than 130 patients for each arm. All of the patients received perioperative chemotherapy, and one group had CRS and HIPEC, the other group had CRS alone. And the results were kind of surprising for the HIPEC community because it showed two things. First of all, that there was no difference with the adding of the HIPEC, no difference in median survival adding the HIPEC, but the expected median survival was 30 months before they started the trial, but eventually they reached up to 42 months for both arms, for the HIPEC and a non-HIPEC. And this is a very, very important slide because we can see that with the proper surgery, with the proper site reduction, without the HIPEC for now, the median overall survival increases very much. It did show also that the morbidity of the HIPEC arm was almost twice as much in the non-HIPEC arm, with 24% all complications, and in the HIPEC arm versus 14% in the non-HIPEC arm. Important to mention that the medium range PCI in the same publication showed that there is only for the median PCI between 11 to 15 had better overall survival and better relapse-free survival. And this is actually what we got from this paper today. A lot of centers around the world focusing now for the colorectal on medium range PCI, and these patients are candidates for the CRS and HIPEC. So the Prodigy 7 conclusion were that oxaliplatin HIPEC has no influence on both overall survival and relapse-free survival. One thing that I did not mention is that the HIPEC that they used was the medication was oxaliplatin, and they used only 30 minutes of perfusion. This was used back then in the years that it was used in France. It's not necessarily used around the world. In our center, we do not use oxaliplatin. In the Netherlands, they do not use oxaliplatin. And also one more thing that is very important that we think is that we use now 90 minutes instead of 30 minutes. Some places in the United States also use 2 hours instead for the perfusion part. But again, if you use 30 minutes with oxaliplatin, there is no benefit for the HIPEC. The subgroup analysis of TPCI between 10 to 15 is improved overall survival and disease-free survival, more late post-operative complications with the HIPEC, and the major part is that cytoreductive surgery alone shows an unexpected satisfactory survival results. Going forward to other modalities of peritoneal metastases, if you look at pseudomyxoma peritoneae, a large study done by David Morris from Australia showed very, very good results, 3, 5, and 10-year survival for the PMP. The largest group of surgeons from Basingstoke in England, led by Brendan Moran, showed the appendiceal cancer and very clearly see that 10-year survival is amazing, with the 70% 10-year survival for the appendiceal cancer. This group, by the way, did already more than 3,000 cases of appendiceal cancer. So the results are good for a center that is doing a lot of HIPEC cases. Going forward to ovary, also we have a study that was done by Van Driel in 2018, published by the New England, randomized study with 2 arms for ovarian cancer, FIGO stage 3, epithelial ovarian cancer. One arm, 120 patients with CRS and HIPEC, and the other one only with CRS alone. Perioperative chemotherapy for both of them. And over here also a benefit for the CRS and HIPEC with overall survival of 45 months median survival versus 33 months, and also better progression-free survival for the patient who received a CRS and HIPEC arm. So general conclusion for the CRS and HIPEC, here we do in Sheba more than 120 cases. The CRS is safe and effective, of course, with morbidity, almost no mortality, but the morbidity is relatively low for the major morbidity. Cytoreductive surgery is of highly importance and especially when it's done in specialized center, and of course patient selection after multimodality treatment. Next modality that I would like to discuss with you is going to be the PPAC, the pressurized intraperitoneal chemotherapy. Here we got we just recently became a training center for the pressurized intraperitoneal aerosol chemotherapy, and this is actually a treatment modality it's a drug delivery system. It's not a new therapy, not a new drug, just a drug delivery system, a way to deliver drug to the peritoneal surface. It comes from the car industry, from the fuel injection actually. Which took fluid and converted it by a special capnoten, special instrument, from fluid to gas, to aerosol. And we can see it on the left side, the HIPEC distribution of methylene blue is good. But if you look on the right side, the PIPEC is very good with the homogeneous distribution of the aerosol chemotherapy. The idea behind it is once we have a high pressure, it will cause higher tissue penetration and lower dose, which we need lower dose of chemotherapy. And the organ toxicity is also lower. First evidence of efficacy also was introduced by Mark Raymond, who also invented this procedure in 2014. Which showed very good peripheral sclerosis. If we look on the left-hand side of the picture, we can see tumor nodules on the small intestine, macroscopic and microscopic. And after 3 PPAC procedure on the right-hand side, we can see sclerosis, macroscopic and microscopic, which means that the tumor reacts to the chemotherapy. What it causes, the aerosol actually, it causes kind of a fibrotic capsule, 2 to 3 millimeter thickness, which prevents from the tumor or hold back the tumor from growing further on, and also prevent from reduce the amount of ascites that the tumor produce. How do we grade the PPAC procedure? So we have a histological grade. It's called the peritoneal regression grading score. and the grade is 1 is a complete, which every surgery we take biopsies, and we can see if there is no tumor or with abundant fibrosis. And PRGS4, which means that there's still a lot of tumor cells with no changes. The more we advance with the HIPEC procedures, we can see the better advances, the better progression with the regression grading. The procedure itself is very simple. It's relatively simple, of course. It's a laparoscopic procedure. We put 2 walk-in trocars. By this one, we can evaluate the PCI, the peritoneal cancer index. We can drain the ascites, and we can take biopsies for each procedure. It takes for 30 minutes. The procedure is done for 30 minutes, which we inject the aerosol. It goes around the abdomen for 30 minutes, and at the end of the procedure, we active evacuate the chemotherapy from the abdomen and finish the procedure. There are no side effects. The only minor side effects will be minor abdominal pain and some nausea. Patient goes the day after they go home. The candidates for the PPAC, actually every patient will have peritoneal metastases from every tumor origin: gastric, colon, mesothelioma, breast, HPV. Every patient that have peritoneal metastases. And the candidates for, we mentioned, it's a palliative treatment. We use it for recurrent ascites. We use it also for borderline patients who are candidates for CIS and HIPEC. One of the trials that we are doing now, prospective trial, it's called NASPIT trial, that we take patient with borderline malignancy. The PCI is medium range, and we do 2 PPACs, and the plan is afterwards to go do HIPEC. Statistical wise, we know that around 10% of the patient that we do PPAC will go eventually for HIPEC. I have to mention that it's a multimodality treatment. It's not instead of the chemotherapy. It comes along with the chemotherapy. Every 6 to 8 months, we do the HIPEC, and we continue the chemotherapy with the medical oncologist. Is it safe? Yes, it is. So we workplace measurements in the operating room where the surgery is and where the anesthesiologist is standing. There is no exposure of the cisplatin in this case or any other drug that we use. Is it safe for the patient? Of course it is. Renal and hepatic toxicities after PPAC, after 1, 2, and 3 procedures, we can see that there's a very few there is no actually liver toxicities, as well as no renal toxicities after the post-day 5. And also if you look after 1 or 2 or 3 PPACs, also again, no toxicities whatsoever. Papers and works, papers around the world started to gaining more and more acceptance, and the recent one, and actually I would say the largest one came from Aliami and Al, a very good friend of mine, and they actually did a systematic search for relevant literature for the PPAC published between 2011 when we started and 2019. And they took actually 1,800 PPAC procedures in almost 840 patients. And they looked at oncological efficacy with ovarian cancer between 60 to 90%, gastric cancer, colorectal, and mesothelioma with very good oncological efficacy. If you look at the worldwide distribution, main centers is doing the PPAC procedure are in Europe. We also have now in South America and 4 centers in United States that started to do the PPAC, and they're working on the FDA approval. If you summarize the PPAC procedures, the PPAC publication and the registered trial, we can see from 2011 until 3 years ago, the numbers are skyrocketing. We can see that they're increasing the numbers and of publications, of procedures, and of trials. And there were more than, up to now, more than 10,000 cases of PPAC procedures around the world, again, mainly in Europe. Ongoing clinical trials, dose escalation to see which doses do we use. There's at least 3 of them right now. Colon and appendix, there's the PPAC OPC 3 and 2. There's our study, the NASPIT, ovarian cancer, gastric cancer, mesothelioma. I can say that gastric cancer is for our experience and also from the worldwide experience, gastric cancer is the one cancer that actually reacts the best for the PPAC procedure. Take-home message from the PPAC part. It is not a therapy, but a drug delivery system. PPAC is safe, feasible, and well tolerated. Best monitoring after clinical response, better than any imaging that we can offer. It exposes the peritoneal to chemotherapy, and it opens new research avenues for peritoneal disease. The last modality that I would like to speak about is the intraoperative radiotherapy. It's the third modality that we use in Sheba, and again, very few places in hospitals in the world has these 3 modalities that we use here. The IRT uses high energy electrons in the most powerful and effective implementation technique. It can be performed as single dose during the surgery or as a boost, followed by reduced external radiotherapy cycle. Usually it takes less than 2 minutes, very quick and efficient. The advantages of the IORT, it improves local control. Once we resect the tumor and we suspect maybe one resection or residual resection, residual margins, it's very good for improve the local control. It reduces the external radiation that we don't need the external radiation. No need to wait between the surgery and the radiation. It is precise and direct visualization of the target, has minimum side effects, less toxic and skin sparing. It adds radiobiological safety margins to surgical resection and does not interfere with the systemic therapy. As for today, the NCC guidelines have guidelines incorporating the IRT in almost every type of tumor that we have, first of all, in the breast, in the sarcoma, rectal and colon cancer, in the pancreas, cervical, and all the others. Technique. The technique is relatively easy. The instrument itself is mobile. It's inside the OR. Once we finish the surgical part, we call to the technician and the intensive radiologist. They come into the OR. We hit the machine for 20 minutes. Then we have the docking part, which is again under direct visualization. We can see exactly where you put the radiation. We have different types of sealers. We have different sizes that we can measure angles, sizes, and depth of penetration of the IRT. Once we do the docking, everyone leaves the room, and then we do the radiotherapy for around 90 seconds. After we finish this, we undocking, and then finish the procedure. What I want to show you here in red is the technique ensures reduction of the dose exposure. So the red is the exact spot that we want to radiate, while on the periphery, the purple is very, very low dose. That actually, this is one of the advantages of the IORT, that there is no collateral damage of the radiotherapy after I finish the radiation. And with that, I conclude our treatment modalities. And so, as I showed you, there's a multimodality treatment. We give the patient at least 3 surgical modalities that are very good and very unique. There are many treatment options, Very important, the selected patients. And I think one of the most important here is the specialized center. If we have a specialized center who is doing the same things in a high volume, this is very important for the patients. I would like to thank you, and now I'll open the floor for questions. First of all, we do give, in our center, number-wise, I would say that HIPEC procedures we already did. We're doing around 120 cases per year. 45% of them is colorectal. Regarding HIPEC procedures, we do around 50 per year. We started it not too long ago, around two and a half years ago, and so far we are approaching 200 cases. The last modality is the IORT, also around 150 cases so far. Most of them we will do with sarcoma, and some of them is breast surgery, and the rest will be recurrent rectum and pancreas. So again, specialized center, as I said before. Another thing that we do, as I mentioned before, we are a training center for HIPEC. Professor Nissan and I already did at least 4 courses of HIPEC in Sheba Medical Center. We had a group from India, a group from Russia, and a group from other Europe countries that came here for 5 days, did the course, and completed the course, and of course received the diploma. And recently we received the approval to become a training center for PPAC, and also we did the first PPAC course hybrid 2 months ago, which was a very good success. And also the physicians that were here received the international diploma to start a PPAC center. Of course, the PPAC center, after you finish the diploma, the first thing you do is you plan for at least 3 or 4 cases, and one of the instructors, either me, Professor Nissan, or one of the instructors for Europe, will accompany the first cases in their own center. Regarding the IORT, this is a bit more difficult because you have to purchase actually the IORT machine, and once you purchase the IORT machine, then we can start working with you on the IORT. Of course, everything is around protocols, getting ready with protocols, and for each one of them, PIPEC, HIPEC, and IORT. If you have any questions, I will be more than happy to answer. Okay, I can see okay, I can see now a few questions. Can PPAC be performed concurrently with chemotherapy treatment the patient is receiving? Of course, PPAC is alongside with chemotherapy. We never stop the chemotherapy, and you can do the PPAC, and the day, usually 1 or 2 days after the PPAC, you go back to the chemotherapy, or vice versa. You do chemotherapy, wait for 3 to 4 days, see that the patient is okay, and then plan for PPAC. Another question: after HIPEC has evolved into PPAC, what do you think will be the next step in this field? Well, HIPEC is not evolved into PPAC, but PPAC is another modality that we use to treat peritoneal malignancies for patients who are not candidates for HIPEC or borderline. The future of HIPEC is a very, very, very good question. In the last ESSO, Francois Quinet, that actually published the Protégé 7, gave a lecture of what is the future of HIPEC after the Protégé 7, and it's a little bit vague because we know that the cytoreductive part is of absolute importance, very important, the resection part. We don't know the chemotherapy part because there's no homogeneity. Everyone does either 30 minutes, either 60 minutes, or either 90 minutes. Which type of drug do we use? Some use oxaliplatin, some use mitomycin, some use melphalan. So the future of HIPEC is of us to investigate, and hopefully in the future, in the next 5 or 10 years, we will have a better answer for this. This is a good question. How many patients have HIPEC, PPAC, IRT, Sheba? So I just mentioned it. So HIPEC we did almost, now we're reaching the 900 patients. PPAC we did 200 cases for 100 patients. As I mentioned, the PPAC we do average of 1.7 PPAC per patient. And we can do between 1 PPAC T, and the most that we did is 7 PPACs for 1 patient. And IRT we did already around 150 patients. Last question I can see: what are the potential complications of PPAC IRT? So the PPAC complications, out of the 200 cases that we did, we had 2 major morbidities, which were gastric bleeding, upper GI bleeding. Both of them were of gastric cancer. And one morbidity was a perforation of the small intestine once got into the abdomen. But it means that 197 patients had no complications. And minor complications, it's more side effects, not complications. It's nausea and vomiting, but mainly nausea and mild abdominal pain for the same day. And usually most of the patient, the average stay in the hospital is 1 day. Regarding the IRT, we did not see any complications regarding the IRT itself. We did see complication around the surgery itself, which most of the patient that we do IRT is complicated surgeries, very, very large sarcomas, very complicated recurrent rectum patients, and very complicated pancreas patients. So I would like to thank everyone for this opportunity. I would like to thank everyone for listening, and we are opening Sheba to every question, and of course to assist and to teach as much as we can. Thank you everyone for this talk.